Hey there, this is Dr. Evan Osar with the Institute for Integrative Health and Fitness Education. Welcome to this edition of Integrative Movement Insider, where we're bringing you the strategies, techniques, and concepts to help you successfully work with your general population clients, especially the older clientele, the baby boomers and seniors, those individuals that really need, want, and will pay you for your expertise. And we just finished up our five-part series on training the female core, and now we're moving on to our next topic, which is training clients with shoulder issues, especially issues related to their labrum. And if you're familiar with the labrum of the shoulder, and we also have one in our hip as well, both ball and socket joints, the labrum really helps to basically suction cup the head of the humerus, so the ball, into the acetabulum, or I should say the glenoid fossa of the scapula. So it's almost like that suction cup that you would hang and stick to your shower wall, that it helps to adhere and hold the humeral head upon the glenoid fossa and sort of keep that suction cup sort of effect and keep the synovial fluid connecting into the joint itself to help provide some stability to the joint. Now, of course, the rotator cuff muscles insert into that and blend into the labrum as well. And then you have the fascial components of the superficial muscles blending in to provide stability as well. So you need that myofascial support that the muscles give you and the fascia gives you to help protect the labrum of your shoulder. Now, many of your clients are presenting with shoulder issues, and the typical presentation of someone who has a labral issue is they have trouble getting their arm overhead, and they especially feel vulnerable when their arm goes overhead, especially in that externally rotated position and full flexion position. Because what happens is, as your body gets, or as your arm gets into those end range movements of flexion and or external rotation, the labrum helps, again, to provide that suction cup effect of the ball in the socket. And when you lose that suction cup effect, then the joint is very unstable. So your clients will often say or relate feelings of, my shoulder doesn't feel stable back here. It feels like it's going to dislocate or pop out of socket. And or your clients have overcompensated and created a lot of tightness where they just can't get their arm into the end range because the body's trying to protect it. I have labral tears in both my shoulders, hence the reason like this position here for me feels very vulnerable. So I can't really do overhead presses, and anytime somebody pushes my arm back in this position, so if I'm getting a massage and somebody's trying to stretch my shoulder and puts it back in this position, I have to tell them to stop because it feels like my shoulder will dislocate. And if you grab my humeral head, you can very easily mobilize it in the joint socket. So the big concept is the labrum helps to create stability, provides a level of stability to the glenohumeral joint or that shoulder joint. And when you have a labral tear, you will often compromise, your client will have compromised stability in their shoulder. So what we're doing in this series and what we want to share with you is how you, number one, assess your client so you can identify whether they have vulnerability in those end range positions so that you don't load them up into those positions. And then share with you some corrective exercise strategies to help your clients stabilize their shoulder. Because even though I have labral tears in both shoulders, from both my chiropractic work and from years of lifting, a lot of these these conditions can be treated conservatively, because I've seen tons of patients in my office with labral tears, both that have gotten treated as far as like had surgery and those that have not had surgery. Many of the ones that have had surgery actually still have problems. So yes, some people that are dislocating, like I just worked with a client, a fitness professional, Sarah, she needed surgery because every time she said she was coughing, sneezing, and or doing anything sudden with her shoulder, she was dislocating it. Those individuals need surgery because they just don't have enough integrity to stabilize their shoulder. However, many of your clients can stabilize their shoulder with using the right strategy. First, you want to determine your client's range of motion, how they're compensating, and how much range they can successfully incorporate into their movements. So we'll look at two simple movements, overhead flexion and rotation. I'm going to demonstrate this standing up. We'll look at it both in standing position as well as lying down. So I'll do the standing version and you'll do the exact same thing as your client is lying down. So the first assessment is just overhead flexion. So you have your client just stand and then have them go flexion. Just flex their shoulder up overhead, just straight ahead, keep the elbow straight, and just have them do it a few times. And what you're looking for is their true end range motion, meaning how far can they get their arm up before they compensate. So for me, that's as far as I can get my arm up. Now I can force it up higher by overextending at my low back here. So I can get up full range, what looks like full range, but when I bring my rib cage back down where it belongs, you see that I do not have full range, maybe about 160 degrees of shoulder flexion. And again, remember, your clients that have labral issues, they will generally have limited range of motion, especially in flexion, because they're trying to protect that end range position. And like I said, if somebody forces my arm into end range position, it'll feel like my shoulder's about to dislocate. The other assessment we'll do is internal and external rotation. And many of us have been taught, myself included, way back in the day, I was taught that most of our clients have decreases in external range of motion. So therefore we were taught to do tons of external rotation work to help stabilize the shoulder in external rotation. And because we saw people's shoulders like this, in this forward shoulder position, so we assumed that that was too much internal rotation. However, you really need to evaluate your client's range of motion. You have to check the range of motion so that way you can accurately determine their range of motion and you're not just guessing. So I'll use the wall here. We'll do this standing up, and we'll also do it when our clients are lying down to get both their active as well as their passive range of motion. So again, all you have your client do is they'll just stand. You can use the wall. They don't need to use a wall. Put their arms, their elbows at 90-90 position, so their shoulders flex at 90, their elbows bent at 90, wrists are straight, and just see how far external rotation they can go. And you can see I can get pretty good external rotation without compensation. Now I'll go internal. And from here, not much. If you ask me to force that range of motion, I can get more, but what happens is I'll have to rotate my shoulder up off the wall. So from the side, here's how it looks. Back against the wall. If your client can get there, they don't need to put their back against the wall. Bring the elbow out to the side, and then go external, and then check out internal. And you can see, to get more range than what I have there, which is about 10 degrees, maybe 20 degrees to be generous, I have to throw my shoulder forward. So essentially it's looking like this. I have to throw my shoulder forward because I don't have the range. That's why your clients are having forward shoulder issues. It's not because they have tight internal rotators frequently. It's because they don't have internal rotation. So in order to get internal rotation, they're throwing their shoulder forward to get it. And again, like I said, that's a very common compensation for labral issues as well as for rotator cuff issues, which oftentimes go hand in hand with labral issues. So this is Dr. Evan Osar with the Institute for Integrative Health and Fitness Education. Thanks for joining us. I hope that helped make sense of how to look at your assessments and evaluate your assessments, true flexion and true rotation, both external and internal rotation of your clients' range of motion. And now in part 2, I'll come back later this week, actually on Friday, and bring you the first step in our corrective exercise strategy to help clients that have labral issues as well as issues with the rotator cuff, because like I said, they oftentimes go hand in hand because the same things that irritate the labrum also irritate the rotator cuff. So thank you again for watching, and we'll catch you next time on Integrative Movement Insider. Make it a great day. And again, thanks Pete for watching, my good friend and colleague, always looking to learn more information. Thanks for watching and being part of these Facebook Lives. Make it a great day.